Hey y'all, it's me, Dr. Smina Rahman, Gyno Girl. Today I want to talk to you guys about vaginismus and sexual pain, and when it's not just the pelvic floor involved. And so I've had some interesting cases in my career, and this is one that I've experienced yet again recently of someone who had a congenital hymen defect. And so I want to talk a little bit about that and when it's not just vaginismus. So let's get at it. Hey y'all, it's me, Dr. Smina Rahman, Gyno Girl. I'm back with another episode of Gyno Girl TV. Thanks for joining me. Please like and subscribe to my channel. I am here to give you the information you need to make educated, informed decisions. I have a podcast called Gyno Girl Presents Sex, Drugs, and Hormones. My tagline is, I'm here to educate so you can advocate. That is why I'm doing this. I really hope that the right information gets out to you guys. I'm a sex med gynecologist, meaning I specialize in sexual medicine, and I'm a menopause specialist in downtown Chicago, as you can see. I have been in private practice. In September, it'll be 10 years that I've been solo trying to make the world a little bit better for sex and menopause. I also am licensed in Illinois, Indiana, Wisconsin, California, and Arizona, so I do virtual visits as well. And I'm very happy to be here trying to educate so that you guys can advocate. And please, I do read your comments. I'm going to get better at responding to them. However, I do balance a lot with kids and entrepreneurship and all the things that I have to do. But I do read your comments and I'm here for them. But today I want to talk about an interesting case that I've seen a couple times in my career, actually. And it's very interesting because a lot of times, even as clinicians, we get sort of tunnel vision when it comes to what we think is going on with our patients. Sometimes we're surprised at the actual cause. And in this video, previously I talked with my pelvic floor PT, Grace Crete, about vaginismus, which is the involuntary contraction of your pelvic floor muscles, leading to feeling like you're hitting a wall, leading to an inability to have any penetration, sometimes no vaginal penetration, sometimes no pelvic exams, sometimes no tampons. It is a very, very distressing situation for most patients. Very hard for them to deal with. And, the American College of OB/GYN has stated that at least 3 out of 4 women in their lifetime experience sexual pain. And so there are many reasons for it. Vaginismus is a big thing I treat in my office. Because vaginismus is also linked to sexual shaming and a high degree of religiosity, I see patients from every religion that grew up very much, not talking about sex, feeling that sex was, dirty or shameful. And so I have a lot of patients that come to me that are either like Muslim, Christian, Hindu, from different cultures all around, Orthodox Jewish patients that come to me with this problem where you have an involuntary contraction of the pelvic floor when you're trying to actually have sex. And many others say, I go through my whole life not being able to have intercourse, and now I'm kind of trying to do it and I can't. And it's not that they don't want to, they do, but their pelvic floor responds differently. It just contracts up, feel like you're hitting a wall. Very distressing. A lot of celebrities have come forward with it. Allure just did a magazine article about it. I talked about it on Instagram over here about vaginismus. I think Meghan Trainor came out with her discussion around it. In the Allure magazine, there are a couple of case studies about it. I've talked about it on my podcast many times. I've experienced it myself as a gynecologist, surprisingly enough. But, we do see this in different cultures, in different religions. We do see this with even not in those scenarios, sometimes as a secondary thing to sexual pain related to primary vaginismus is where that's all that's happening. There's an involuntary contraction in the pelvic floor. Secondary is when it's due to, maybe it's due to hormonal deficiency at the vestibule or secondary to vestibulodynia. And this, and other causes that cause you to then involuntarily contract to your pelvic floor because you're anticipating pain. We know that 3 out of 4 patients in their lifetime can experience sexual pain. So it isn't like it's uncommon. It is common, and sexual pain is not normal. And I want to emphasize that once again, that if it is that's what you're experiencing. Many times I talk to patients and they're like, oh, I'm a little dry. And then they clearly have significant pelvic floor dysfunction. They're clenching their jaw, they're clenching their pelvis, and they're creating a hypertonic pelvic floor where the floor of the muscles that kind of support. Here's a great graphic from Pelvic Global about your pelvic floor muscles. It supports your organs down here, your structures, and it's very important for your bowel and bladder function, your sexual function. And so what happens is if you involuntarily contract enough, your muscles then will also become hypertonic because you're just used to clenching. You're clenching your jaw, you're clenching your pelvis, and then the muscles become shorter, they become less oxygenated, increased lactic acid, increased burning sensation at the opening, sometimes weird itching, other things. And, with vaginismus, sometimes there's no telling, like you can't even get any penetration. And and we grade it based on this Lamont grading. Grade 1, 2, 3, 4, like grade 4 to 5 is like you're just coming off the table, your buttocks is raised, you're going off the table. Here's the Lamont grading. And so I think that, something I treat very often in my office. Pelvic floor therapy is essential. Dilator therapy, where, we're trying to desensitize these muscles, right? It's almost an anxiety reaction of your pelvic floor. Like, oh crap, I'm getting penetrated and this is not something I should be doing, or this is going to hurt. And so your pelvis automatically contracts without you wanting it to. You're trying to, and my patients are always apologizing to me when I'm examining them. I'm like, it's not your fault. This is your body responding to something that it thinks it's dangerous to them. And so, your muscles are contracting. It feels like a wall that you're hitting. And so, patients get a lot of distress for it. It leads to unconsummated marriages and relationships so many times. People end up divorced over this. I've had my podcast where I discuss vaginismus with a couple of patients and friends. You can go over there, my first couple of episodes. And, it can ruin, people's relationships. It can distress their lives. It can cause havoc. And again, it's not that, these patients are not wanting to. So there is sometimes a history of sexual abuse, but not always. And very rarely do I see it in my office that's the primary reason. But we do have that, obviously, traumas from before, aggressive pelvic exams, medical trauma. All of these things can actually lead to a form of vaginismus. And so it's really important to understand that as a clinician trying to guide a patient, right? Like my patients, all of them have said, oh my God, the last time I talked to my gynecologist, he or she told me to just have a glass of wine, to relax, your significant other needs to try a little harder. I mean, these are things patients tell me that they are told. And I believe it because I hear it every day in my office. And so, again, standard treatment is dilator use at home, try to desensitize those muscles. Sometimes we use vibrators down there. Pelvic floor physical therapy is crucial. And then, I use a lot of vaginal Botox in my office. Sometimes we use suppositories with muscle relaxers and, and anxiolytics that come with it. Many times I use nitrous oxide or laughing gas to even examine patients in the office because they've been either so traumatized from previous exams or they're just so scared, they work up. And so sometimes it helps me to even just do an exam. And many times I can't do the exam even because their vaginismus is so significant. We often see patients who are trying to have intercourse later in life experience it even worse. So I have patients who are like, oh, I was quote unquote a virgin for 30 years and 35 years and all of a sudden this happened. I tried to have intercourse and I couldn't. And remember, as a side note, I talked about virginity and the hymen in a previous YouTube where we know it's a social construct, and I'm going to talk about the hymen today because the case I'm going to present is related to that, but it's not actually like anything that is there for a purpose. And really, like, it can stretch, it can tear, it can do everything even way before intercourse. So the whole idea of hymen testing is BS. And you can go to my other YouTube video that I created on hymen testing and what the membrane of honor, as many of us, like I've referred to it as before, because so many cultures view it as such. And so that's where I discuss a little bit more about that kind of social issue. But again, virginity is a social construct, a cultural construct. I apologize. I did stray from what I was talking about, which was vaginismus and the treatment. But, the reality is, like I said, dilator therapy is very critical. Pelvic floor physical therapy, you have to get that physical therapy done and regularly. I have patients that'll start and then they disappear because it's too much for them. I have patients that, I think the longest unconsummated relationship or marriage that I've seen in my practice has been like 10 years. And the more time that goes by, the harder it really is to get past it. And many times patients, if they're having intercourse with men, those guys will develop erectile dysfunction. They can develop premature ejaculation and other problems. So it's always a couple's issue, right? When we're dealing with intercourse, like it's not just a one-sided thing, but we have to address both sides. And that's why sex therapy is also in the mix. And sometimes sexual counseling and coaching can be really beneficial if we think it's primary vaginismus. Okay, so back to the case I wanted to talk about, which is kind of unique. I had a patient this past year who came to me in her early 30s, not able to have penetrative intercourse, has been trying a couple different times in her life, in a really good relationship now, very happy with that person, wanting to have intercourse, grew up, I think, maybe a strict Catholic at that time, and had very negative ideas about intercourse when I saw her, or at least grew up with that. And then, so we talked about her pelvic floor. I was not able to really do an exam in the office. She was like grade 4, off the charts, really like her buttocks. She retracted her buttocks and she kind of went off. She was really grade 4 when it comes to like vaginismus. Like she retracted her buttocks, she pushed back. Like anytime I tried to actually even retract the labia. I talked about vulvar exams in my last video. And so when I was trying to do a vulvar exam, it was even just that, not even trying to put a speculum in, that caused her to like jump back all the way to the top of the table. So, and then we tried Pronox, we tried a lot of different things. Nothing really helped. I had her take an anti-anxiety medication before she came in. Nothing really helped in that capacity. So I had her start seeing my pelvic floor physical therapist. And she, maybe got a finger in at a time. Maybe they were able to get like the very smallest dilator in. And, really, I couldn't even like do an exam. I couldn't get more than a pinky in. And so in those scenarios where the vaginismus is very severe, there is a model of care to do vaginal Botox under anesthesia. And it was created by a plastic surgeon, PACIK. He actually retired in 2015, I believe, and is a plastic surgeon who studied severe vaginismus extensively and used vaginal Botox under anesthesia. And I think, when doing this in his cohort, had, close to a 97% success rate of sexual intercourse and penetration at the time of his studies by 1 year or something like that, post-Botox, if I remember correctly. But anyway, with his regimen as a multimodal approach where under anesthesia you inject the muscles with vaginal Botox. If there's any part of the introitus that is too, like if you have a thick band, you can actually sever that band or try to, loosen it up, give a little anesthetic in there, progressively dilate the patient under anesthesia, and then leave the largest dilator in, which is supposed to flip a switch in their brain to be able to use dilators better at home. And so this was our goal with this patient who had gone, a couple months of trying dilators at home, trying suppositories, using Pronox in the office, and still not even able to get a good exam there, right? And so we're like, okay, we have to do this when you're relaxed under anesthesia because the buttocks is, retracting, you're going off the table. This is very difficult to assess. And so we agreed to do this vaginal Botox procedure under anesthesia with progressive dilation and anesthetic, a long-term anesthetic to the pelvis as well that would help with pain relief, with the risks and benefits discussed, and so we were going for it. This is something I have done with a lot of patients in the last 5 or 7 years or so that have very severe, like grade 4 to 5 vaginismus that, just can't even get a good exam in the office after even once I'm trying pelvic floor therapy, dilator therapy, and at home suppositories. And so when we took the patient to the operating room, prior to standard procedure, I was thinking that once the Botox goes in, we leave the dilator in and, the patient wakes up, it flips a switch, and she goes home and she starts dilator therapy within the next week and pelvic floor therapy and gets very aggressive about it. And then usually patients do really well because the vaginal Botox, of course, forces the pelvic floor muscles to relax, but also decreases pain sensation at the opening. And so it has a twofold effect. And it's about 100 units that we utilize, plus or minus, depending on the patient. And so under anesthesia, I finally got an exam. She was totally rested, not contracting, and this is what I saw. This is an imperforate hymen. So she had another reason for it, right? Like you're just in again, tunnel vision. I treat this all the time. We think that This is related to, upbringing, to late coitarchy, all the things that we know are correlated with it, sexual shaming and other things related to it. But this is what I saw. And an imperforate hymen means that at the time, let's talk about the hymen for a second. The hymen is just a membrane that covers the vagina. Again, I talked about it in a previous video. It has no biologic purpose. It does not correlate with virginity or anything that's a social construct. But in situations where the hymen is being created in utero, it comes from the same area that the vestibule comes from, the urogenital sinus. I've talked about vestibulodynia a lot here. And so it's part of the embryological development. By like 20 weeks, we're getting the vagina to develop and it canalizes. We're getting the hymen to canalize, right? So initially it's totally covered and then it's supposed to rupture and open and be open by the time you're born, right? To have a little bit of an opening there by the time you're born. And so sometimes it may not rupture or create that opening or canalization even before the first month of life, but most of the time it does that prior to being your birth, right? So an imperforate hymen means that you were born with a birth defect that caused sexual pain, a birth defect that caused you to not be able to enjoy sex or to have exams or to have anything else. Now, hers was a partially imperforate hymen, right? Because if it was totally imperforate, that means the whole hymen would be covered. And so she had just this one little area. Sometimes people develop vaginal septums, which that's what I was concerned about. Sometimes people develop vaginal septums, and I was concerned about that too, but under anesthesia, I could see it was just one thick membrane in the middle that didn't totally rupture at the time or prior to her birth. And so sometimes, imperforate hymens, if they're severe, or vaginal septums, which are just these walls in the vagina that create problems with reproductive capacity as well as, sexual concerns. And sometimes they're associated with other congenital things like, kidney problems and other things. So, there is that. But an imperforate hymen happens like 1 in 1,000, right? So it's very rare, but I've seen it at least 5 or 6 times in the last 10 years because of the nature of what I treat. And so it never surprises me, but it always humbles me that there are other things that are going on when it comes to, sexual pain. And so this is a congenital thing that happened to this patient. It was something that she never knew about. Some people are born with a totally imperforate hymen, so there's no hole there at all. And so those are the patients that usually get diagnosed in adolescence or teenage years when they're having their routine exams, or when they don't menstruate by the time they're 16, 17 years old, they haven't gotten a cycle yet, but they have cyclical abdominal pain. So the blood is still coming into the vagina. It might create an abdominal mass that looks like a mass on ultrasound, but it's just a collection of blood or mucus. Some people have bowel dysfunction and bladder dysfunction related to that because of everything. Some people, maybe it's associated with endometriosis because you can get retrograde flow into the pelvis that way. So that's if the hymen's a total cover, right? The garage door is shut. There's nothing coming in and out. And so those patients usually get diagnosed much earlier. But this is a patient who was able to get a finger in, who was able to menstruate because it was coming out of that little opening, and she just couldn't have intercourse because of this thick membrane that was, so basically we had to incise the membrane, and then I did the Botox, and then I did some more anesthetic stuff and the sequential dilation and all of the things. She's now doing well with, pain-free intercourse. And so this is, one of these things where some people are born with these issues that you can't help. This is not your fault. This is not anyone's fault. This is a fluke of nature, right? It's similar to what we think people who are born with that congenital neuroproliferative vestibulodynia, born with too many nerve endings at the bulbar vestibule. I talk about vestibulodynia in this video. And so again, it's congenital. It's not your fault. This is something that you were just born with, and it was a fluke of nature. And so that's something I feel like, we all need to be aware of. It's very rare, but there are treatments for sexual pain. There are treatments for pelvic floor dysfunction. There are treatments for vaginismus, and there is hope for you. All of the therapies I discussed, along with sex therapy, and sometimes it's cognitive behavioral therapy if you have significant anxiety. If you're anxious, you're clenching. You clench your jaw, you have TMJ, you got pelvic floor dysfunction, So these are the things that we have to think about. And that's why treating sexual dysfunction is a biopsychosocial phenomenon. But this was an interesting case of someone with a rare congenital disorder that created a problem for her for years and years and years. and didn't get a diagnosis until she saw me. And so she had never had a pap smear either, I should say that, because it was attempted and it was like aborted many times. And I think it's, some doctors didn't go further to look at what was happening. And then patients start to not wanting to go to a gynecologist after a while, right? After a while, you're just like, oh, I've just heard it before. I've heard it before. I just need to relax. I need to have a glass of wine. I need to do these things that they're telling me, which is telling me it's in my head. But this is biology, guys. This is biology. Not everything a woman experiences is in her head, right? A lot of times it is, and a lot of times it comes to become a problem in your head. But it didn't start there. This didn't start there for her. This was something she was born with. And so that's why I get annoyed when everyone always says it's always in their head, because it's not. And this is the foundation of gynecology, unfortunately, because it's just the chronic disbelief of a patient, a female patient of color. These are the women that are being affected and suffering for years on end without help. There are people like myself who are gonna, try to help you the best that we can, even when we don't know for sure. And we'll always be humbled by biology. So that's it, guys. That's my little case study for today. I have many of these case studies if you like them. I just thought this was something to talk about because sexual pain is so common. And even though this is rare, I doubt, everyone's going around with an imperforate hymen. But it is something to consider because I feel like, it's not always looked at. And so that's it for today. That's my little spiel on vaginismus, painful sex, imperforate hymens. If you have more questions or concerns, post them here. I'll try to follow up with that. Please like and subscribe to my channel. Please join me on my podcast. I'm Dr. Smita Rahman. I'm Gyno Girl. I'm here to educate so you can advocate. And I'll see you next week.